Thanks everyone for being here this morning and for the opportunity to present on, I think, the future of where BPH should be treated early and within our office. So here are my disclosures, and one of my always disclosures is Dr. El Ali. That's my first BPH surgeries I ever did. I did that for about 2 years. Then I learned how to do a TURP. Imagine that. So, and we've also helped launch ProCare, sort of a multidisciplinary tumor board for BPH. So manage not just the surgery, look beyond the prostate, beyond surgery. So BPH is a new, old issue. It's something that, if you look at the length of life of humans, really since World War II, we got to a point where we even meet PSA guidelines for screening. So this is only an issue in the last, let's say, 3 generations that have become an issue, and with it, the plethora of men that we need to treat is going to get really big. And so we know that in the next 10 years, the number of men or humans worldwide is going to double or triple. And sprinkle on that, if you look at our AUA census, that Dr. Rohrburn, he likes to look at the data, he scrunched those numbers and said, hey, look, even if we all, look at all the urologists that are available to deliver health care, and if we brought those people to see at least one BPH patient a day, for those doing 2,500 or 5,000 encounters a day, most likely that would overflow that office. So there's not much of a chance we're going to be able to do all of this and deliver this kind of care moving forward. So enter mists. I think this is what patients want. I think what we would like to have, that we can do something that's going to be quick, relatively painless, quick return to recovery. Something that's going to be fast in terms of delivering results and hopefully, last a long time. But, the idea of that durability, is it once in a lifetime, or does it have to be maybe done in a few years later? But, can it be redone? Can we move on to a different therapy? Until we find the cure of BPH and that trigger, what's that light switch that starts at 40, that process, is it inflammatory, is it hormonal? We still haven't gotten that. I think that's really the key. But until then, we have this. We have the UroLift system that was approved 2013, so now 11 years into it. You look at Rezūm, approved 2015. Let's say a little coding issue, then picked up by Boston Scientific and then launched with bigger input. We have iTind, FDA approved 2020, and recently, since November, since the data that was just shown on the Pinnacle and Everest trial, the Optilume BPH system. So, to me, in my practice in Canada, we don't have maybe the same level of the coding restrictions that you can't do some of these procedures, or you're kind of limited to doing these procedures in an office setting, because they can be done with good anesthesia. I think as a urology community, we've embraced becoming better radiologists, the whole purpose of this meeting. And 2, I think we're becoming better anesthesiologists. And I think we have the tools, and we don't really look at this. And I invite the AUA and others to bring us to become better local blockers, perineal blocks, pudendal blocks, and some of these other modified Bears techniques. So for those who do their prostate biopsies, you can deliver anesthesia below the seminal vesicle, puncture through the seminal vesicle into the white clouds, they say, and even puncture into the transition zone. So it's something that I've been doing, sort of a modified Bears technique, kind of what, if anyone's seen the Shalin catheter, this small catheter where you inject lidocaine into the transition zone, which kind of makes sense. We're delivering treatments to the transition zone, but we're shoving some lidocaine underneath the seminal vesicle and hoping it's going to work. It does do a good job, but there's things that we can do better, including some of the inhaled agents here. So UroLift, I think that's a technique that everyone understands. It's been around for a while. It's very individual, so everyone here who does a UroLift may deliver different results in terms of angles, number of sutures. It's very technical. We know that the tissue is not all the same. So when you look at transition zone, we all worry about the Pyrad's lesion and so forth, but does every transition zone the same? Is one side different than the other in terms of the amount of stromal or glandular tissue? We'll touch base on that, some of the radiation after. But again, genomically and embryonically, we don't do a good job of measuring that, right? We just kind of, we're just going to put some tacks in. But one side may not compress as well as the other, as you can see in the insert here. Rezūm, same idea. You're now doing something else. Instead of putting energy to compress, now you're injecting heat, which over time will deliver a 30% reduction in volume. So for every 1 centimeter length, a 9-second puncture, a positioning of 0.42 milliliters or 208 calories injected into about a 2x1 little oval area that will initiate cell death. And the tissues will slough, and we know that on average, for relative independence of the size of the prostate, we published on this around 34% volume reduction, but it takes time. It's not your Amazon Now delivery. And there's going to be some sloughing, and for those who have do this, there is a bit of I call it uropsychology, a little bit of nursing, reassurance, antibiotics, coaching, hugging. I call it uropsychology. It's another practice. And then we get into the iTind and the Optilume, which I think are unique because they're independent of anyone's hands, skills, age, whatever. So if you put an iTind in, if you inflate what I call the turbo, the transurethral radial dilating balloon opening of the prostate, as long as you have 3 fingers, 1 eye, and something to hold the device to rotate, you will deliver the same outcomes independent of one another. And that's different than the other 2 techniques. No heat, and our goal here is really to raise the roof. We're staying away from the floor where all the important areas are, the trigone, the ejaculatory duct, and we're making 9-foot ceilings into 20-foot ceilings. And if you remember back in your days of physics, it's called Pasteur's law, which is the resistance of any tube is its length over radius squared. So within the seconds or days, we're increasing that height, kind of like a zipper on your suitcase. If you want to get something at the bottom of your bag, you can drill a hole in the center of it, or you can open the zipper. And if you open the zipper a couple of inches, less resistance. And so that's what we're seeing here is the ultrasound view of the Optilume fully inflated. This is during an office setting that we do our procedures in, and you're just inflating that balloon up to 4 atmospheres for 10 minutes. So again, the iTind temporary, it's a nitinol device that kind of looks like a corkscrew that you hold your champagne bottle on. It's got 3 stents, 1 at 12, 5, and 7, like a TUIP. And I call it the shepherd's hook. I used to be a lifeguard, so that was my thinking. When you're looking at the Very, you watch the shepherd's hook pop over, and you're done. And you leave a string out, and you take it out in a week or 5 days. So the premise there is a slower necrosis, let's say, of the tissues, mainly at the 12 o'clock incision. And what we're seeing there are the improvements across the board. So I call it the reproducibility factor. If I have my dad here and I send him to everyone here in the audience and have a TERP, chances are he's going to have very different TERPs. If you have a hole-up, there's only one way to do hole-up. You're going to get the same results. But with, again, to these technologies, that's something that we don't really factor in, is that are we all delivering the same outcomes? And I think that's one of the things that we have with iTind and the Optilume. So you're really creating that anterior commissurotomy, and you're getting the split. So I'll show you this, what that looks like. You don't see as much at the bladder neck, because I think you can't really rip muscle as well as you can rip a sponge. So that's really what the adenoma is. You'll get some mucosal venous bleeding, and you'll see that, I always say, like, can you find the commissurotomy? I'll squeeze the bag, I'll try and get a view here, but you can see it on ultrasound that we got to the capsule. So I'm not going to spend too much time on this awake patient to demonstrate that. But the key finding here is that if you look down below, you're going to see that the complete floor from the bladder neck to the verumontanum is untouched. And that's really the beam here. That's where that, I call it the prostate trigone, the most sensitive part of the bladder and the prostate are, the nerve endings are. If we can mitigate that and keep that structure intact, we don't have any impact on ejaculation. So again, another view just of the ultrasound. With this inflated, we're waiting 10 minutes, deflating, catheter goes in. Data shows, significant improvements in IPSS up to, at least in the Everest trial, up to 4 years, and they're going to be publishing another 5 years shortly. And the striking thing is that immediacy. I like to look at the first 30 days. We always look at 3 months, but what about that first 2 weeks, the first month, the journey of the patient calling off their office? That Qmax is very different than the Qmax of my Rezūms or what have you at 1 month or 2 weeks. So jumping ahead now, look into the future. Lots of stents coming out, a lot of nitinol, so stents 2.0 I call it, and you're going to be seeing, words like Zenflow, Pro V, so like from Ireland, if you're a golfer, Pro V, Eurocross, the expander, and the latest one is from Rivermark, which is called the Flow stent. So I'll go over those really briefly, but the Zenflow has a proprietary hand delivery system. It's kind of a unique cysto. You blow up a balloon in the bladder, and then you squeeze the handle of the device on the right, and what you're doing is you're putting 1 of 4 sizes in that's going to sit there in the urethra to be permanent, but at any point you don't like it, like your shoes, if they outgrow them, you take it out and you can put another one in. So just a quick view here of, you're going into the bladder, you're going to blow up a balloon, you're going to pull the balloon back against the bladder neck, and then you'll squeeze 3 times deploy the device, and if you don't like it, you can reposition the spring, and once you're happy, you release it, and then it's meant to be staying there. And if you do want to take it out after releasing, you'll have to take it out with a special snare. So here's our balloon at the bladder neck. We're going to pull traction, and you're going to squeeze 1, 2, and 3, and you'll see this kind of spiral like your kid's notebook at school. And you want to deploy that third one just behind the verumontanum, and that's where measuring of the urethral length is important. So immediate results, the TMIS, the office-based procedure, which is kind of what we want, like angioplasty. Proverum, just another Nitinol device meant to sit in place. One size fits all for their device, so they're looking at their 2-year data shortly. And finally, the Rivermark kind of initial human studies have been published through the works of Dean Elterman. What's unique here is this could be put through any cystoscope, a flexible cystoscope. It's meant to be done in the office, not anywhere else. It's your extension of a cysto, and you pass this proprietary delivery system. It springs open in any prostate 2 to 5 centimeters, and you're getting results right away. So this is the initial series that was published, presented at AUA this past year, and looking at 34 men, all 34 men successful delivery and well tolerated. And you can see these are the 2-week results looking at IPSS changes. So again, first in man, just to show efficacy, and they'll be publishing their other data shortly. So with that, I think the idea that we should be doing more BPH procedures in the office and using our OR and OR at a time, more to our bigger cases. So I think my final thoughts are, I think compared to oncology, we are still in kindergarten. We're looking at X, Y, Z. Are you anticoagulated? Middle lobe, yes, no. That's our algorithm. And I think the idea that we have to look at other things beyond that, looking at measuring using ultrasound, handheld. So I'm using the Clarius, getting better assessments of the urethral length. And the urethra in the prostate is not a tube. I think that's why stents 1.0 failed. They're not round UroLift tubes. They have a different eye shape and have different areas of different angles, different heights, tissue elasticity. And I think the idea, like my kids play hockey, so when they want new skates, they have to go step on a special machine. It molds their foot, and therefore we can pick the right skate for that foot. So why don't we have that for the prostate? It's not a tube. As you can see the silicon structure. There's, for those who do rigid cystoscopes, or when you're doing your Rezūm and you're doing you're almost down on the knees like you're praying, and you're doing the Top Gun, the Mach 5, you want to get up high. You don't recognize that with your flexible cystos, and I think that's something that has to be factored in, because those angles play a big role in urinary flow. So with that, I think the future is going to be improved transition zone imaging. We'll have our own PIRAD system to know, is this a very dense stromal tissue or glandular? Will it be able, should I put some steam in it if it's made of cement? Probably won't going to work, right? It's going to hiss when you do your Rezūms. Why does one sound beautiful and one sounds like the whole bed shaking? Probably because of this. So there's a lot of things that we need to look into genetics, and finally, some of the anatomic features to help predict who's going to be better for which stent. Thank you.